Hi, welcome everybody. I think people are still trickling in, but maybe we'll get going just in the interest of time to make sure that we stay on schedule. So welcome everyone. If this is your first set of Citywide rounds, for those of you that are repeat offenders, welcome back. So these are our Citywide rounds, as the name implies, and the idea is for you to share expertise and content which you may not necessarily see at the site that you're working at. So it's a great opportunity for you to showcase some of the interesting stuff that you're seeing on a daily basis, but also to see some content that you wouldn't otherwise have access to. Again, I just want to thank all the presenters and their supervising staff. It is a lot of work. We appreciate it, but I think your colleagues appreciate it even more. On that note, just be aware that this is being recorded and we share the recording with our colleagues in Ethiopia. So it actually acts as an educational resource for another site as well. So we are grateful to you for allowing that to happen. If any of you have any objections to this, please let me know either now or by email if for any reason you don't want to have your recording put into the presentation. Okay, so we're going to kick off. Tonight's theme is hepatobiliary, and our first site is Sunnybrook. And I'm very sorry, but I don't actually know who is presenting from Sunnybrook, and I believe you didn't send in any questions either, so you may just need to introduce yourself and say,
Oh, this is me,
me being Renuka.
but I'm having some issues with with my computer.
Okay, so would you like maybe some mics to go first and then we can come back to you? Would you prefer that?
Yeah, sure, but I sent my questions. I sent it. I sent them.
Okay, so Alison did not have any questions for you as of today. I've actually checked with her multiple times in the last few days. There were only 3 people who submitted questions, and I don't believe you were one of them.
I received a confirmation email today,
From
actually.
who? Okay, sorry, I don't want to hold up the proceedings. Do you want to go ahead with your case then? And I can look and see if your questions have been uploaded, because they hadn't been when I checked at lunchtime.
Yeah, sure. I can go ahead and do my presentation.
Yeah, go ahead.
I need to adjust this because I think my speaker is not correct. I'm so sorry.
I believe you're presenting from St. Mike's. Do you think you're ready to present? And maybe we would give Renuka some extra time to get herself together?
Yeah, I'm ready.
Okay, sure, great. So why don't you go ahead? And I know we have your questions embedded.
Are you able to see my
Okay.
screen?
I'm seeing Daniela's
Sorry,
screen. Is
I'm
that you?
not listening.
Sorry, are you Daniela?
So why doesn't St. Mike's go ahead, and then we'll get Sunnybrook to present after St. Mike's.
Okay, great. Thanks, Chirag. And are there 2 people presenting from Sunnybrook?
No, just one person.
Okay, perfect. Thanks for clarifying. All right. Okay, you go ahead and then you let me know when you want your questions launched as well, okay?
Okay. My name is Arwa Lanizi. I'm one of the abdomen fellows here in St. Mike's Hospital. I will be presenting a case which was discovered incidentally. This is a 70-year-old female underwent an abdominal imaging ultrasound for a follow-up of her known hepatic steatosis, and there was an incidental finding discovered during the scanning. There was a pancreatic mass. It appears hypoechoic with solid component and central cystic spaces. It was almost arising from the body and tail region, and it is measuring 3.2 centimeters. And it is not causing any main pancreatic ductal dilatation or biliary dilatation. And on Doppler imaging, it shows an internal vascularity in it. So it is basically of a solid and cystic part. After that, MRI was ordered to characterize this lesion. And on the T2, there was a solid and cystic part within this capsulated solid mass, which was located in between the body and tail region. And on the coronal view, as you can see, it is abutting the greater curvature of the stomach with no definite invasion to the surrounding structures. And on T1 sequence, it was iso-intense in the periphery, but in the central part, it was hypo-intense due to the cystic spaces. And in the in and out of phase, there was no drop-off signal to indicate an internal blood or fat content. As well as on the MRCP, there was no communication with the biliary duct. It was appearing like it is displacing the biliary structure without any definite communication. The arterial phase showed a peripheral rim of hyperenhancement, as well as in the delayed phase. The contrast was retained there. There was no signs of washout. And in the ADC and diffusion, there was a diffusion restriction for this lesion. And also a CT scan for metastasis workup was done. It was negative for metastasis. And the lesion on the plain image did not show any also hemorrhagic content or calcifications. And the same enhancement was seen in the arterial and delayed phase compared to the MRI imaging. So the differential diagnosis was made to include mucinous neoplasm, cystic neuroendocrine tumor, and less likely to be a solid pseudo papillary epithelial neoplasm because of the patient age. Also, the CA19-9 was normal for this patient. The patient did a distal pancreatectomy and partial gastrectomy, and the histopathology proven that this is a moderately differentiated neuroendocrine tumor with acystic changes. This is an article from the AGR. It was published in 2013. They did the study for the pancreatic neuroendocrine tumors with cystic-like changes evaluation among 37 patients who underwent a resection for a known neuroendocrine tumor. And they came up with this result: 17.8% of all the pancreatic neuroendocrine tumor were predominantly B cystic, and between 50 to 100% are cystic. The cystic changes was slightly more frequent in the smaller tumors, if it is either equal or less than 3 cm, compared to the larger tumors, which was only 14.3%. And the imaging features for these neuroendocrine tumors with cystic spaces, the main feature was found that it shows a peripheral arterial rim enhancement as seen in this case. And about 85% of all the cystic pancreatic neuroendocrine tumor. The arterial phase is crucial to detect any pancreatic mass. And some of these neuroendocrine tumors, especially if they are purely cystic, they can be greater mimickers for the IPMN, MCNs, and serous cyst adenoma, or even pseudocysts. Also, they found that these cystic neuroendocrine tumors, they predominantly located in the neck, body, or tail region, and less likely to be found in the head and uncynated process. And they behave more benign. the cystic part, about 8% of them, they can metastasize, unlike the completely solid neuroendocrine tumor. 49% of them, they can metastasize either to the lymph nodes or to the liver. But in general, they are well differentiated and less aggressive. Cystic neuroendocrine tumor should always be in the differential diagnosis of any pancreatic cystic masses, and the arterial phase CT protocol is crucial for the detection. Thank you.
Howard, did you want any of your questions launched, or that's redundant now?
No, it's okay. It can be launched.
Okay, so I will do that now. Okay, so you should be seeing them on the screen now. Okay, you have short answer questions as opposed to MCQ.
Should I answer them, you mean?
No, you've asked for people to give a written answer as opposed to giving them multiple choices, correct?
Yeah.
Yeah, so usually it's a little bit more straightforward if you give people an MCQ, because that way we can certainly look and see whether things have got better before or after you taught them the information that you wanted to give them. But this is fine. We'll just have a spectrum of answers, I guess, now that you've given the presentation. So there are 4 questions here, guys. If I could just scroll through them, or maybe just magnify it up a little bit. Here we go. What are the main differential diagnoses for a cystic pancreatic lesion? How common are pancreatic neuroendocrine tumors? How frequently do pancreatic neuroendocrine tumors present with cystic changes? And what are the key imaging features of cystic pancreatic neuroendocrine tumors? We've had 4 people take part. Remember, this is all anonymous. I'm not going to be calling out any answers or anything. So feel free to cast random votes or say what you like, depending on what you learned from the presentation just now. I'm going to open the poll for about 10 seconds longer. So. Okay, so we've had 6 of 38 people participate. All right, I'm going to end the poll, and here are the results. Oh, I don't know if you want to say anything about your results. You'd like to discuss anything there?
I cannot see any answers actually for these questions. Should I stop sharing to see them?
You can stop. Yeah, you can stop sharing. I don't know why it's actually not displaying anything. I can see myself that 7 people have answered it, but I'm actually not seeing what they've typed. Yeah, I don't know if I can help. It's actually not displaying the answers here at all. Okay, I think we're going to have to stop this poll. So I'm going to move back, and I believe it's Daniela now who is presenting.
Yes, ma'am.
Okay, and so Daniela, you have been renamed, so go ahead and present your case.
Okay, perfect.
You need to stop sharing.
Okay, perfect. So can you confirm you're seeing my screen, please?
Yes, we can see it.
Okay, perfect. So this is Daniela Carrascal. I'm a body imaging fellow in Sunnybrook Health Science Center. So today's case is a 66-year-old female admitted with COVID-19 pneumonia. She has a prior history of end-stage renal disease and intermittent hemodialysis, hypertension, type 2 diabetes, asthma, hypothyroidism, eczema, and a prior cholecystectomy. She was admitted to the ER following 3 days of respiratory symptoms, and she experienced rapid deterioration requiring ICU admission after 3 days admitted. She was intubated with a high PIP. 8 days since her admission to the ICU, she started presenting with raising ALP and ALT, also elevated white blood count, likely related to active infection. So they asked for an abdominal ultrasound 9 days post-admission, and we did a focused abdominal ultrasound where you can see there are no gross liver abnormalities, no focal liver lesions, although there was a mild central intra and extrahepatic bile duct dilation that was most likely related to prior cholecystectomy status. 2 weeks after the initial admission, she had disproportionate worsening ALP and ALT up to 1200 with normal bilirubin levels. So, in the context of a normal abdominal ultrasound or grossly unremarkable, the clinicians consider she was having a cholestasis of sepsis plus minus prior drug-induced hepatotoxicity. 3 weeks after she was extubated, the liver function tests were downtrending. The ALP went to 987, and by the 4th week, she was discharged without any respiratory symptoms. However, she did had persistent abnormal LFTs. By the 5th week, she was readmitted due to fever and rising LFTs. The ALP went up to 1000, but the bilirubin level started to increase up to 22. So they ordered another abdominal ultrasound to rule out obstructing causes. Again, no gross hepatic abnormality, no focal liver lesions, but the mild central intra and extrahepatic bile duct dilation was slightly bigger, slightly more prominent, but the common bile duct contained debris in this ultrasound, although no gross evidence of cholecystectomy within this imaging technique, and no intrahepatic duct dilation. So this patient was treated empirically as presumed clinical ascending cholangitis, and she was discharged again by 6 weeks. In the 7th week, she was readmitted again for ERCP due to worsening LFTs up to 1600, but the bilirubin level was persistently increasing up to 67 in this case. They did the ERCP and they discovered copious amount of purulent bile, and their diagnosis was minimal esophagitis with dilated biliary tree with purulent bile and slushed. She was treated again as a recurrent cholangitis, and she was discharged 3 days after the ERCP was performed. By the 8th week from the initial admission, she was readmitted again due to progressive elevation of FLTs. She was checked continuously before her intermittent hemodialysis sessions. And when she was readmitted, they ordered a CT abdomen and pelvis. And these are the images that we have. This is the axial arterial phase. And this is the axial portal venous phase. And after this comes my question.
Daniela, you'd like me to launch your question now or just wait until the end of the CT?
Just wait a second. Guess I'm gonna show it here as well. Okay, so what is your most likely diagnosis for this patient right now after seeing the CT? You can pull the question now if you want. How's the pool going?
It's going well. We have 22 participants so far in 24 actually in the first question. Some people are skipping ahead to question number 2, which may not have been your intention. So I may just stop the poll now and then we might relaunch it.
Yeah, sure. It's okay.
So you're just going to see the results now on the screen.
Okay, so 36% of the people selected recurrent pyogenic cholangitis and 40% of the people selected ascending cholangitis secondary to obstructing occult stones. 16% selected multifocal hepatic abscesses and only 4% secondary sclerosing cholangitis and biliary chlornorrheitis. Okay, so continuing with our case. So basically what we saw was diffuse intrahepatic bile duct dilation with interval development of innumerable small peribiliary lesions that were consistent with small peribiliary abscesses, of course not drainable, biliary wall enhancement, and periductal enhancement of the liver parenchyma, consistent with cholangitis, that could be related to prior interventions as well. But we see that here we have tiny hyperdense content within the common bile duct, as well as within the intrahepatic bile duct. This is a segmental branch for segment 6. So in a context of hepatic abscesses, well, the clinicians considered the patient was having hepatic abscesses and persistent biliary obstruction. So they repeated an ERCP, and they decided to place a biliary stent. In the following ERCP, they discovered sizable soft debris and mucopurulent bile, and their diagnosis was retained cholecystolithiasis. By the way, the bile culture was positive for Candida albicans. They also requested an MRCP thereafter, and this was the image. So So here goes the second question. Now, what is your favorite diagnosis?
You just give me a second. I just have to clear the results from the last time and I'll relaunch it, okay?
Okay.
So everybody just vote on question 2. You don't need to vote on question 1 again. You should be seeing that on your screen. And closing the poll in 10 seconds. Great participation, by the way, for these questions. Okay.
Okay, perfect. So we'll still have a majority for recurrent pyogenic cholangitis, up to 43%, also ascending cholangitis, and only 21% for secondary sclerosing cholangitis. So I'm going to keep going. And in the clinical context of a patient with hepatic abscesses and retained cholelithiasis, we have this MRCP showing persistent intrahepatic and extrahepatic biliary duct dilation without gross obstructing masses, now identifying wall irregularities with bedded appearance of the intrahepatic ducts, some of them showing this low T2 signal filling defects associated with multifocal complex cystic lesions adjacent to the biliary ducts, such as this one, which shows heterogeneous T2 signal content, likely representing debris in it, and this bedded appearance that I mentioned. So in the context of this patient with widespread diffuse intra and extrahepatic biliary duct dilation with multifocal bedding and a structuring of the biliary tree, we're in the diagnosis of a secondary sclerosing cholangitis likely associated to a critically ill patient. After the diagnosis was set, she was readmitted again for biliary stent placement, and they did another MRCP, only 12 days apart from the baseline MRCP. And we see that there has been gross progression of the disease with enlarging of the velomas and interval new development of multiple new ones, and subsegmental and segmental involvement of pretty much all the intrahepatic biliary tree. 12 weeks after, she was admitted for a percutaneous biliary drain, which was removed over 2 weeks. No resolution of the cholestasis, and placement of the stent. And finally, 5 months after her initial admission, she had a rapid progression to biliary liver cirrhosis, finally admitted with hepatic failure and ascites, now identifying gross imaging features of liver cirrhosis with the compensated portal hypertension, and of course, the gross involvement of the intrahepatic biliary tree. So, as a quick review of the topic, the secondary sclerosing cholangitis is a mixed cholangiopathy, which has both ischemic and inflammatory etiologies. This usually has a rapid progression to an irreversible biliary cirrhosis, and the clinical context of these patients are is hypotension and reduced hepatic blood flow, and mechanical ventilation with high PEEP, such as our patient, in the context of critically ill patient, right? And this happens around 0.05% of all the ICU admissions, up to 1 in 2,000. It's more common in men, 9-to-1 relation, and it's usually around 50 years old. It happens in prolonged ICU stays from 30 to 40 days. It requires for an ischemic etiology to have at least a mean arterial pressure under 65 millimeters of mercury for at least 60 minutes. And the classic presentation is increasing liver function test after 4 to 9 days. So the pathophysiology is a very complex because we have two theories here. The ischemic injury due to its particular susceptibility of the biliary tree, which is supplied by the peribiliary vascular plexus and, making it very sensitive only to necrotic injuries due to its only arterial supply. And basically what happens is we have cholangiocyte necrosis leading to fibrosis and stricture. And the more susceptible parts of the biliary tree are the middle third of the common bile duct and the hepatic confluence. And also we have another theory that's called the toxic file in context of sepsis and SARS. We have a disruption of the balance of the hydrophobic bile acids that precipitates altered lipid membrane of cholangiocytes, leading to bile duct damage. So basically what happens is that the biliary epithelium starts desquamating and leads to the formation of those biliary casts that we saw previously, and following dilation of the bile ducts. Also, the severe ischemic insults lead to transmural necrosis of the bile ducts and biliary leakage, forming or creating those bilomas. For the diagnosis, most of the patients are asymptomatic, but they start becoming or presenting with jaundice and pruritus. The classic abnormality of the paralinx is elevated GGT by up to 50 times its normal limit, and also bilirubin levels up to 50 times its normal limit. So for the imaging modalities, we have ultrasound that has a low diagnostic accuracy up to 30%, but it's usually our first imaging modality for this patient to rule out obstructing etiology. The thing with the abdominal ultrasound is that they're mostly unremarkable. Also, the CT is not our preferred imaging modality, although it gives us anatomic detail and a context of any extra hepatobiliary features in the abdomen. The MRI and MRCP are our preferred imaging modality with high sensitivity and specificity up to 97 and 98%, showing us bedding and stricture of the biliary tree, and the biopsy has a limited diagnostic value as the pattern for chronic biliary obstruction is not specific. So regarding imaging features, first we have to see casts, biliary casts, that show as intraductal filling defects, usually T1 hyperintense and biliary tree dilation, of course. This has this linear and branching morphology. The thing with the biliary cast is that they're insoluble and adherent to the biliary duct. So treatment for these cases is very complicated. Second, we're going to have a stricture and infiltration. So we're going to see this multifocal, segmental, and subsegmental intrahepatic bile duct dilation associated with a stricture disease, as we're seeing here. And it's more commonly intrahepatic. The extrahepatic bile duct are involved in around 20% of the cases. And at least we have to check for progressive destruction of the peripheral biliary tree, with this burnt appearance indicating significant destruction of the intrahepatic bile ducts, leaving only the central biliary system intact up to the second bifurcation, as we're seeing here. Finally, talking about prognosis, this patient usually present with acute liver failure, and they rapidly progress to biliary cirrhosis. Their 1-year survival is around 55%, and cholangitis is a negative predictor for patient survival, as we're seeing here. Also, the placement of biliary stents and an age older than 47. We have to look carefully for these patients' follow-up studies to rule out acalculous cholecystitis, recurrent bacterial cholangitis, and hepatic abscesses, as they are common in this group of patients. For treatment options, sphincterotomy with cast drainage is an option, but it is a temporary solution, as I mentioned before, because biliary casts are insoluble, so they stick to the biliary tree. Also, ursodeoxycholic acid has a palliative effect, but liver transplantation remains the only curative treatment for these patients. So finally, the take-home point is that this is although this is a relatively uncommon diagnosis of late, has seen significant increase in recognition and reporting of late in the last 5 years, at least. For this critically ill patient, persistence of cholestasis after clinical recovery, as we saw in this patient, has to make us think of irreversible anatomical biliary lesion. And the practical approach for these cases are to first rule out for obstructive and ischemic causes, so consider history of surgical manipulation of the liver and the bile ducts, hepatic arterial insult, or chemotherapy such as HIAP patients, biliary stones, trauma, neoplasms. Second, rule out infectious causes such as recurrent cholangitis. Third, consider secondary sclerosing cholangitis in critically ill patient, in this patient that has prolonged ICU state. And fourth, to rule out immune cases, so considered or look for systemic features and drug history. Thank you very much.
Thank you very much, Daniela. That was a great case. Anybody have any questions for Daniela? Okay, so I'm going to switch to JDMI next, and I'm not sure whether is it Rodrigo or Aniket first?
Hi, Dr. Chawla. It's Aniket here. I think Rodrigo finished a little bit later and he's just getting home. So I am happy to do my presentation.
Perfect. You go ahead, and again, just let me know when you want your questions launched.
Yeah. I think with the questions, it might be a bit tricky. Because anyway, we'll just get through it. So hi guys, my name is Aniket. And I'm one of the fellows at JDMI, and I'm presenting something in HBAB, which I guess we will get to in a second. So hopefully you guys can see my screen right now. I will be hopefully picking some people from the audience, and I'd love some audience participation with regards to describing the cases and stuff as well. So we'll just dig right in. So just going to the first case straight away, and just going from what the sequences are, so out in T2 fat set, pre-contrast T1, T1 arterial, portal venous, delayed, and then we've got a primivist delayed right at the end. And just give everybody maybe 20 seconds to have a little look, and then we can get into the next question. And I'm happy to describe the findings as well. So basically, on the in and out, we've got loss of signal on the outer phase. So that's suggestive of hepatic steatosis. We've got multiple lesions that are T2 hyperintense. And on the pre-contrast, they look mildly hyperintense. That's obviously on the background of hepatic steatosis. And then we've got lesions that are arterial hyperenhancing, remain hyperenhancing on the subsequent phases relative to the background liver. And on the portal venous phase, on the primivist phase, majority of these don't retain contrast. So if everybody is happy with that, we'll just kind of dig right into the first question. So I think if we go to the poll, more likely than not, it's going to ask the next question, which will probably give us a bit of a hint on the diagnosis. But yeah, I'm happy
What I
to.
might do is just leave the first question up, and then if people can try not to go on to the next question and spoil the here, 1 second, and just see if I can change it a little bit so that you're only able to. I'm assuming you can still see it even if I change.
That's fine. I think we're going to find out regardless in about 30 seconds. So
Okay.
I can go back to the previous
So
slide.
about 20 people have voted. I'm just going to end the poll so you can see the results, and then we can go back to your next. I'm just sharing the results now.
Yeah, excellent. So perfect. So yeah, we've got overwhelming response for hepatic adenomas, which is what this ended up being. And I guess that will take us to our next question. So next slide. So basically, yep, my presentation is about hepatic adenomas. Hepatic adenomas have been around for ages, obviously, and then there has been a lot of research that's been done on them. And I think there's like a French group that has probably done the most predominant research with regards to kind of characterizing the different types of adenomas. So in essence, yeah, they're benign hepatocellular neoplasms with distinct genetic, pathological, and clinical features. I think up until like 2015 or 16 in general literature, there were the three big types, which were inflammatory, HNF1 alpha mutated, and beta-catenin. And then the fourth was unclassified. And then subsequently, since then, they've obviously had better testing and figured out sort of the genetic markers and stuff with the different adenomas. And then after that, we've got Sonic the Hedgehog subtype, mixed inflammatory and beta-catenin. So it's just a mixture of the two beta-catenin subtypes with inflammatory as well. And majority of the times, they tend to be more inflammatory than the beta-catenin component. And then there's a smaller percentage that is unclassified still. And I'm sure probably in the future, we'll probably have more subtypes as we do more testing. So just digging into the next question, just getting a bit of an idea about what people sort of know in terms of knowledge. So what subtype is most associated with a risk of malignant transformation? So if we could do the second poll.
Yeah, just give me 1 second.
Thank you so much, Dr. Chawla.
Yeah. So just vote on the second question, please, if that's okay. And we have a fairly even split. I'm going to close the poll in 10 seconds. Okay, and I'm just sharing the results.
Yep. So no one thought inflammatory, and the most common was beta-catenin exon 3, then beta-catenin exon 7/8, SHH, and I guess inflammatory nobody really thought. Okay, so yep, for the people that voted beta-catenin exon 3, that is definitely true. So it is the most common subtype that is associated with malignancy. And I guess when we're in the future, I will go through majority of the subtypes that are associated and what the risk of malignancy is. But when we see a lot of these statistics about what the malignancy rate are, I think it's really important to keep in mind that we're talking absolute risk. So overall absolute risk of malignant transformation in literature, they've said is about 5%. Then they've done surgical sort of studies and stuff where they think it's 4%. I mean, the reality of it is probably a lot less than that. And so it's kind of taking the actual number in context of how common these lesions are, and then again, what the overall risk associated with the lesion is in itself. And we'll just go to the third question straight away as well. So which risk factor is most associated with risk of malignancy, subtype, size, chronic liver disease, or being male?
We should be seeing those results up on the screen.
Okay, so subtype people have said was highest associated with risk of malignancy, size, then being male, and chronic liver disease. So this is a kind of a tricky question, and I think I would have probably gone with that as very similarly in terms of risk as well. And it's a bit of a trick question because all of these are technically associated with risk of malignancy as well. The actual real answer is a bit more tricky than that. I can't say that it's one is definitely right over the other, but being male is the highest associated with risk of malignancy. So if you had the same subtype of adenoma, and they were, maybe not beta-catenin 3, if it was one of the other ones, whether it's inflammatory or HNF alpha or whichever one it is, your overall risk of it being malignant is higher if you're a male. Yeah, so that's sort of the thing to really keep in mind is if you have a male with adenoma, then the overall risk of malignancy is higher. And obviously they have a predisposition in setting off like glycogen storage disease and stuff as well. So we'll just get into that. So just going to the next slide. So first, we're going to talk about inflammatory adenomas. So I should mention that the first case that we saw was also inflammatory adenoma. So they are equal in terms of commonness with like accounting for 30 to 35% of all adenomas. They're tied with FNH1 alpha, and they are strongly associated with people with higher BMIs and long-term use of OCP. And other risk factors also include alcohol use, fatty liver disease, and glycogen storage disorders. Again, most adenomas are generally more common in women. In terms of the imaging features, so they have moderate T2 hyperintensity, which we could see on that first case, and that's related to like dilation of the sinusoids. And if they demonstrate an atoll sign. So atoll sign is basically this rim of high T2 signal that has a very high specificity for inflammatory subtypes of adenomas. Again, as I was saying, associated with fatty liver disease. So the lesion may not itself have fat. However, the background liver will have fat. So that's, again, what we saw with our first lesion as well. And yeah, most tend to be hypo-intense on hepatobiliary phase, but some can be hyper-intense. And the malignancy risk is roughly 6%. Again, keeping that in context that the overall risk of all adenomas is like 4%. And then you got to think about how common each one is, and then think about the malignancy risk. So it is relatively low. And hemorrhage risk is like 13%. So we're just going to go to the next one. And maybe for this one, I can just get somebody to describe this for me, if that's okay.
I don't want to pick on anyone, but Carl, I can see you on my screen, and this is great exam prep for you. You have a target audience. Do you want to describe the findings?
Hi, Dr. Chawla. Yeah, for
Thank you very
sure.
much, Dr. Fowler. Hey, Carl, thank you so much for participating. Much appreciated. Yeah, mate, go for it. And yeah, just go through what you think the findings are, and then I guess, you know, describe what you think it is.
Yeah, no problem. So we have a series of MR images. We have, I mean, I'm not going to talk about sequences, but in the outer phase and in phase, I don't see a signal drop between the, sorry, there's a lobulated capsulated mass, I think centered around segment 4A, maybe
Yep.
would be as well. Hard to really see the extent craniocaudally. There is the capsule itself, I think, is T2 hyper intense and is well circumscribed. It doesn't look kind of infiltrative.
Yep.
I believe that the bottom sequences are progressive arterial, portal venous, and maybe delayed phases. I wonder if the last sequence is a subtraction
It's a primivist, so it's the 20-minute delay.
or like a hepatobiliary delay. Okay.
That's it.
In the enhancement sequences, I think it's most hyper enhancing, or it's kind of increasingly, it's most hyper enhancing at the portal venous phase and even at the delayed phase without with signal drop at the delayed 20-minute phase, with kind of punctate loss of signal on delayed phases.
Yep.
I don't see a diffusion scan or a diffusion ADC.
Yep. Yeah,
I don't
there's no
see
diffusion changes.
there are no diffusion changes.
Like
Okay.
no restricted diffusion, sorry, I should say.
Okay. So overall, this is a lobulated mass in the left liver lobe with essentially hyperenhancing component with a T2 hyperintense rim with signal dropout at the primivist hepatobiliary phase. There's no central scar, a T2 central scar. It doesn't really follow a typical adenoma where it's kind of hypo-intense in the hepatobiliary phase, although there are components of that. In the, I think, outer phase, I think there are areas of signal dropout actually, sorry, within the central component. And I wonder if that's macroscopic fat. I think this is atypical, but I would probably go with a hepatic adenoma given the intralesional fat.
Yeah.
But it can be anywhere between the FNH adenoma spectrum, I think. But I'd go hepatic adenoma at this point.
Yeah, nice work, Carl. That's excellent. Yeah, when I was looking at this case the first time, I found the intralesional fat thing actually quite tricky. But I think you're right. Like there is some dropout on the outer phase over there as well. And again, like if you didn't have that T2 sequence over here, I don't know if you guys can see it, but the T2 sequence, I think, kind of makes it a lot better to understand, obviously, the intralesional fat. But essentially, as you're saying, this is an arterial hyperenhancing lesion that maintains hyper enhancement on all the subsequent phases. And just on the primivist phase, I would have said that there is contrast retention in majority of the lesion. right? So I think you were right that in your mind you had kind of brought it down to, is it an adenoma or is it an FNH? And I think this rim of T2 signal that you're seeing just at the margin, this is the atoll sign that we were talking about in the slide before. So this, I guess, really helps us kind of break it down to think that, hey, this is probably more likely going to be an adenoma than over an FNH. So yeah, this is what an inflammatory subtype of adenoma is, and I think this was path proven. Oh no, maybe they just monitored this one. And this was a adenoma, and I think the patient had subsequently gone on to stop her OCP, and this lesion got smaller and smaller in size over time. So that's an example of an inflammatory subtype of adenoma. Thank you so much, Carl. Okay, so we will go to the next one, and I would love someone to again be able to give us a description of this as well. And Carl, if you want to go again, also happy for that as well.
I can try again. It'll be quicker
I
this
was
time.
going to say, we don't normally pick on people. I feel very bad that, Carl, the first time you've attended, you have been picked on, but thanks for doing such a stellar job.
Yeah, Carl, that's fantastic. Just keep
Don't feel
going.
obliged to have to do it again. There are lots of other people on this call. Anyone can take this case.
Can I take this case?
Yes, please.
Okay. The lesion on the T2 sequence, it appears as an evil gray, slightly intermediate signal, and it is dropping of signal in the out of phase sequence. So it indicates an internal fat content, and it is low signal in the T1. And for the post-contrast images, there is a peripheral heterogeneous enhancement. I don't know about the washout. Maybe there is a bit of washout at the periphery on the delayed phase.
Yep.
And for the pre-movus, there is no uptake.
Yep.
So due to the presence of fat, my differential will be an adenoma. The other possibility, it could be an angiomyolipoma of the liver or an HCC because it can contain also fat.
Yeah. So those are all sort of great ideas.
Yeah.
This again,
But
woman
it doesn't have any aggressive feature to say it is like an HCC. It is well capsulated and not displacing or invading the blood vessels.
Yep. And again, I think this woman was like in her mid to late 20s, not your sort of classic population for HCC, but definitely something to think about when you have a fat containing lesion. That's the one I guess you don't want to miss. And that was a great description. And yeah, again, on the primivis phase, we don't have any contrast retention here. So that was right. So, and do you want to take a guess as to what type of adenoma it would be?
It could be the alpha type.
Yeah, excellent. So that's what this is. So it's the FNH1 alpha. So this is this equal most common lesion amongst all hepatic adenomas. They're associated with germline mutations, can be seen in a specific subset of patients with mature onset diabetes. And so they actually end up having this FNH1 alpha mutation, and that is what actually predisposes them to getting adenomas also along with mature onset diabetes as well. Again, mainly females, but it is not associated with OCP use and obesity. And I guess in contrast to the first case we saw where there was hepatic steatosis in the liver, in this, there's no hepatic steatosis actually within the liver, but the lesion itself has microscopic intravoxel fat. So imaging features. So the intravoxel fat is very important. And then showing arterial phase hyperenhancement with washout. Maybe that case wasn't perfect for the washout, but they generally tend to have washout as well. And they very, very, very unlikely to demonstrate retention of contrast on the hepatobiliary phase with primivis. This lesion is, very low risk of malignancy. And there's risk of symptomatic bleeding, but again, it's quite low. And these are the ones that are not, just because you stop the OCP doesn't mean they'll actually go down in size, where the inflammatory adenomos generally tend to kind of reduce in size. So I'll just show just a quick case again, because this is just another HNF1 alpha. Unfortunately, this one was interesting because there's a little bit of enhancement at the inferior portion that I just couldn't show very well on the pictures. But again, we're seeing that sort of quite significant dropout of fat and these lesions. And this one was actually taken out and confirmed to be HNF1 alpha adenoma. And again, just showing another one. But in this one, we've got hepatic steatosis that's there, but the lesion is actually a little bit darker over here and a bit brighter. And then subsequently, this also ended up being FNH1 alpha. So just moving along. So this is a young male patient, and they basically have a liver lesion. Does anybody want to have a go to describing what it is? Maybe I will pick someone. Why don't we have do we have Neil on the line or Kevin?
Hi, Annika, it's Neil. Yeah, sure, I can give it a go.
Excellent, Neil. Thank you so much.
So there's a lesion kind of anteriorly, probably in segment 5 or 8, which on the T2 fat sat, slightly high signal, so slightly high T2 signal. I think there's probably a little bit of signal dropout on the outer phase T1, which might suggest a bit of intravoxel fat. And then on the kind of post-contrast sequences, so I think there is some mild enhancement, which looks like it kind of continues through the dynamic sequences, and then I think it kind of looks quite similar to the background liver on the primavist face. It probably does retain some primavist as well. So yeah, I think it would. I guess the talk is on adenomas. So I'm almost certain it's an adenoma, and I guess that kind of the tricky one can be, I think, with the primavist. It almost gives the impression it has a scar, but like a central scar. But I think the fact that it has that high T2 signal is quite unusual.
Yep, excellent. And like I guess we've gone through inflammatory and HNF alpha. So taking a punt, what do you reckon? What type of adenoma is this?
So I guess beta catenin is the one we haven't done.
Yeah, excellent. So yes, so beta catenin is the other subtype, and essentially we'll just. So beta catenin, so at the moment they have 2 subtypes of beta catenin. So exon 3 and exon 7 and 8. Again, all this molecular stuff I find really tricky because until we kind of see the diagnosis on some sort of histopath, it's hard to know. But it's just going forward, I always find it to be kind of useful to try and mentally get an idea around the histopathology. So then you have a better understanding of tumor biology, I guess. So in terms of what they are, so beta catenin mutations, they exist, and the reason why it's important is they're implicated in up to 35% of HCCs. So it's a common mutation in HCCs itself. The beta catenin subtype overall account for 12% of all hepatocellular adenomas, and 8% of those are exon 3, and roughly 4% is 7 and 8. So it's like a 2/3, 1/3 split. So exon 3, so that's the one that we were initially saying that was associated with the male sex. So 30 to 40% of cases are in men. And then they're associated with anabolic steroid use, vascular liver disease, and also glycogen storage disease as well. And that's more seen with the 7 and 8 subtype. So with exon 7 and 8, essentially there is no specific imaging features. The exon 3 has some imaging features, again, not so specific, but I guess we had 2 cases that kind of showed it. So as Neil was saying, the exon 3 can have a T2 hyperintense central scar. And up until kind of doing a lot of this stuff, I always used to think that just because a lesion would retain primavist, my idea is it's probably not that bad. But that's not always true. And that's all to do with what the primavist is. It's to do with the OATP1B1 receptors. and if they're upregulated, and obviously normal hepatocytes have them, which is why they can take up the primavist. However, the beta-catenin mutation itself causes the lesion to upregulate those receptors. So unlike the other adenomas, majority of these will actually be hyperintense on the hepatobiliary phase. So I think that's like one thing to be important and like kind of keep in mind. Other thing as well is like, I guess when lesions are transforming, so all the different lesions, I guess inflammatory and HNF alpha have slightly different mechanisms to where they go from a benign lesion into a more aggressive lesion. So HNF1 alpha and Y can become malignant. They don't really understand, but they don't think it's related to the beta-catenin pathway. Whereas the inflammatory ones think that there is more expression of the beta-catenin mutation, and then subsequently that's how they can become malignant. And sometimes that when they have adenomas that go from not retaining primavist to start retaining primavist, that can be sometimes a marker that there's more expression of beta-catenin mutation, I guess. And as I was saying, the risk of malignancy is highest associated with exon 3. And the overall risk of HCC is tumor size, chronic liver disease, male sex, and subtype. And going back to the initial question about what the most common, what is the most likely subtype to actually go into having HCC? So exon 3 is most likely, whereas the exon 7 and 8 mutation is almost negligible. And so I've just got one more case I just kind of wanted to show it again. So, sorry, all the cases that all except one of the cases that I've shown so far have been taken out and proven on histopath. So this one is this large lesion, intermediate T2 signal. It's got a central scar. I guess no significant fat dropout, maybe a little bit. And then we're seeing on the post-contrast phase is arteria hyperenhancing. Then it kind of blends into the background liver, but we can see that central scar gets brighter and brighter. This one, I guess they didn't do a hepatobiliary phase on, but that's just a good example to demonstrate the actual scar itself. So this was proven to be a exon 3 subtype of hepatic adenoma. As for the other ones, so the mixed ones, the Sonic the Hedgehog, unfortunately, I couldn't find any histopath-proven cases of that on our packs. But essentially, the most important, it doesn't have any specific imaging features. And I guess the only other thing about it that's important is they're most likely to bleed. So that's pretty much it for my talk. I was going to do a little bit on treatment stuff, but I guess the treatment stuff is so variable everywhere that it can be a bit different. But essentially, it just comes down to like not every adenoma is going to get biopsy, first of all. So the molecular stuff is kind of tricky until either it reaches a certain size or there's some specific feature that they're concerned about that will lead to them, if it's a male or something like that, that would lead to them doing biopsy. I think all patients basically go through the usual thing, given that it's far more likely in women and sometimes, and it is associated with OCP use. So if they're on any sort of OCPs or androgen intake or anything like that at all, and they're sort of told to stop them. And then weight reduction obviously is another one because it's associated with obesity. And then basically they monitor adenomas based if they're growing smaller. And as long as they're less than 5 centimeters, I mean, the paper that I read on radiographics was saying essentially if they're less than 5 centimeters, then they will just continue to monitor them with MRI surveillance. If they're in men, I think the article basically said that all hepatocellular adenomas should be taken out in men, but I don't know if that's actually definitely true. Certainly I saw some that were taken out, but not all. And if in women, if there's anything that's growing and getting bigger than 5 centimeters, then it gets taken out. And if they're not reducing in size after stopping any sort of predisposing factors, they also can be surgically removed. There's other forms of treatment as well with regards to TACE and ablation as well. But yeah, I'm not 100% sort of clued in on exactly how the management algorithm works for adenomas. Yeah, so that's pretty much it for me. Does anybody have any questions?
Thanks a lot for a good presentation. Sorry, I might miss that part, but for the second case, you had the primary uptake in that adenoma and also fat. So did you? Was it a kind of a steatotic adenoma or a beta catenin?
Is this the case that you're talking about?
Yeah, exactly.
Yeah. So with this one, this wasn't biopsied. So this was the only one of the lesions that I had that wasn't biopsied. And I think the overarching sort of feeling was that, I don't know if you guys can see my mouse moving, but essentially on the T2 signal, that high rim of T2 signal surrounding it was why they thought it was an inflammatory adenoma. And so after that, I think they just said, we'll see how the patient goes after stopping OCP, because I think she was on OCPs. And then subsequently, this has progressively reduced in size over time.
Okay, perfect. Yeah. So yeah, because it has overlapping features between different subcategories of adenoma, but yeah, but
sorry, I see what you're saying, that the liver wasn't fatty in this one. Is that what you were implying? And the lesion had a little bit of fat?
No, I mean, it has intercellular fat, and also primoris retention, pretty similar to the liver, and also this atyl sign, so had some overlapping features between the subcategories of adenomas.
Yeah, sure.
So that makes it very interesting. But yeah, unfortunately, we don't have any paths for for OATP3 receptors, but that's okay. Thank you very much for the follow-up and for great cases. Thanks.
Hey, thanks very much, Aniket. That was actually a great spectrum of cases and a very comprehensive discussion. You also managed to pull in lots of people, which was, I'm sure, an unexpected surprise for them. Okay, Rodrigo's online. Rodrigo, would you like to present next?
Of course. Good afternoon, good evening, everyone. Just 1 second, let me share my presentation. So let me see. Sorry, just 1 second. Let me see if I'm able to share with you. Okay, are you able to see my screen?
Yep, we can see your screen. It's in slides sorter mode right now.
Oh, slides mode. Okay, sorry. Let me see. How can I do that then? Is it still as presenter or? Sorry, just one question, one second. Excuse me, let me try again. Is it working now?
Yep, all good.
Okay, perfect. So my name is Rodrigo Borrero. I'm one of the abdominal imaging fellows at UHN, and I would like to present you specifically 2 cases, which are more than tough cases. I found them interesting. So the first one is a 51-year-old male patient who had a biochemical evidence of an insulinoma with negative scan and a previously failed MRI. These cases are courtesy of Dr. Korosh Khalidi. So the first images are here to show you, this is a video of an abdominal CT which was actually, this is the negative one. The pancreas looked normal in density. There were no focal lesions, no main pancreatic duct dilatation. I can show it just one more time. And regarding this case, they decided to avoid doing for now nuclear medicine studies. And then we tried to look for a different approach, which was with ultrasound. So here we do have ultrasound images using different probes. The first two images in the upper portion are with 10 and 11 megahertz. And what I wanna show, are you able to see my mouse or not?
Yes.
Okay, so it's this focal lesion in the anterior aspect of the proximal body, which is isoechoic to the pancreatic parenchyma, but also demonstrates a hypoechoic halo in the periphery. Here with the 11 megahertz, it's even better delineated. And sorry, just one second here. This is with an 18 megahertz probe, which I want to show you this area in here, where is this hypoechoic nodule. Also here, I would like to, let me see, are the videos playing? Yeah, okay. So here, this is one I want to show you in here is the nodule, well-defined nodule. And here's, I want to show you the vascularity of it. I want to show you that it's hypervascular on Doppler with super microflux. And this here, it's actually with 33 megahertz. And these images in here, the lower portion, are actually done intraoperatory. So this is basically to show you how intraoperatory ultrasound is very useful, even when the previous scans were negative. So this patient underwent a wedge resection. And one of the things that I want to tell you just in a couple minutes, it's very important, is the distance between the lesion and the main pancreatic duct here. So in this case, it was 1.8 millimeter of distance, and we're gonna discuss it in the next slides. So I want to talk you very quick about what pancreatic neuroendocrine tumors as insulinoma are. They are rare tumors with an incidence based on single center cases. So for example, in Mayo Clinic, it's a 0.4 of every 100,000 persons per year. In Sweden is even less, and in Japan is 0.3. The benign to malignant ratio, they're usually benign with an 8:1, and almost 10% of them are associated to MEN1. The pathogenesis is not very, very clear. However, it's supposed to be arising from cells from the ductular/acinar system, different from neoplastic proliferation of islet cells. How do these patients usually present? Is higher levels of insulin despite hypoglycemia, and many times they do present neurological and psychiatric disorders. So many of these patients actually are treated before coming to imaging with neurological or psychiatric disorders. The tumor characteristics, they're usually singles, however, they can be presented as multiple lesions. They're usually very well localized, but sometimes they do present metastatic disease, which is rare. And almost every insulinoma, more than 90% remain within the pancreatic parenchyma. So what advantages do we have of intraoperatory ultrasound in pancreatic neuroendocrine tumors? These are portable. They give us real-time information. They use we don't have any ionizing radiation, and we don't need a patient preparation. What else is very important here? It gives us a very good image of where is the tumor localized. Also helps us to determine the extent of the surgical resection, and also improves the tumoral staging. So what I wanted to show you here is that it can have a very important impact during the surgery. As you may see, the changes in what the surgeon is going to do may change from 2.7 up to almost 49% of the cases where they finally decide to do between a distal pancreatectomy or a Whipple's or just a wedge resection of the area. So what other applications do we have? It's basically very useful for proper localization of the known lesions for assessment of surgical planning. Sometimes it's very useful to detect and characterize the small lesions that intraoperatively they cannot feel, like the surgeon tries to see if they can see or note the lesion, and sometimes it's more deep than they can feel it. So there is a important utility of ultrasound. It can also give us a very important assessment of closer vascular structures and how is perfusion. And also there are some, when it's not for a resection, it can also be a guide for biopsies, ablation, and determine the margins of resection. It's also one of the things that I wanted to show you in the cloud is to evaluate the diameter or the distance to the main pancreatic duct. So the typical appearance of these lesions on ultrasound are well circumscribed masses, which are hypoechoic in relation to the surrounding parenchyma, and sometimes they do present this halo around the tumor, just as the cases that I showed you. So there is something, we can do the question, Dr. Shaula, please, the first one. I know I haven't explained it. We'll discuss it just after the question, if you're okay with that.
Yeah, I'm just gonna launch, give me 1 second.
Thank you.
Okay, so I'm assuming you just want people to answer the first question?
The first one, yes, yes, yes,
Yes,
just the
okay.
first one.
Somebody who's very enthusiastic and is voting on question 2. You don't need to do that just yet.
Yeah, yeah, we can discuss it later, yes.
Okay, I'm gonna close the poll in the next 10 seconds. Anybody want to vote? Go ahead. Okay, 3, 2, 1. And here we go.
Perfect. So most of the people voted for more than 2 to 3 millimeters. And okay. The second most voted was 1 or 2 millimeters and more than 5 millimeters. So great. The ideal measurement is at least 2 millimeters. It's safe, and it is basically to avoid any fistula. Also considering that not just the main pancreatic duct might be close, but also tiny side branches might be also close to the lesion and might be the cause of the fistula. So usually, to call it safe in terms of surgery, more than 2 millimeters is considered safe. So what other applications can we see here? It's to determine the size and the appearance of the main pancreatic duct. And in patients with malignant tumors, it's to see the broader resection margins. Usually the lesions measure less than 2 centimeters to be ideal for enucleation or wedge resection. And the problem, one of the things that they also consider is in terms of location, is if the lesion is at the head, they usually require a major surgery such as Whipple's, different from lesions at the neck, body, or tail, where if they don't find any other lesion, if it's not more than one, and if there is no metastasis or lymphadenopathy, usually enucleation or wedge resection is enough. So great. The second case I wanted to show you is a 73-year-old male patient with epigastric pain and 10 kilo weight loss. And an ultrasound showed a mass in the pancreatic head. So this is a scan. This scan was read basically unremarkable. Up here is a video. And I want to tell you, yeah, I can run it multiple times if you want to. And the thing is that it was read as basically unremarkable. But if I hope you can see, there is a very thin hypodense halo surrounding the pancreas. However, it's very, very subtle. And retrospectively, so I wanted to show you here that this is the main pancreatic duct, and here we kind of lose it. And we can see it here as well. But there is no main pancreatic duct dilatation here, and it looks almost as strictures. Here on the sagittal images, we can see it here as well. And also note the extrahepatic bile duct dilatation. So these are the ultrasound images of these patients. And let me put. So I want to show you here, it's the heterogeneous, appearance of the pancreatic parenchyma diffusely. Also want to show you here also on these images, it's all this area. Here it comes, the main pancreatic duct. I can show it to you again. It's here. Oh no, sorry. It comes here. But just one more time. The main pancreatic duct is just right here. And I want to show you here in the static images, there's kind of a hypoechoic halo surrounding the main pancreatic duct. And there is also this hypoechoic halo, which is more evident on the ultrasound images compared to the previously shown CT. Also, want to show you that this is the heterogeneous focal mass that was noted at the pancreatic head. So it was an IgG-related chronic pancreatitis, which the IgG level was 0.9 milligrams over liter. And this is basically to talk very short about autoimmune pancreatitis, which is an inflammatory type of subacute pancreatitis. As we already know, there are basically two types, the lymphoplasmacytic and the neutrophilic. The first one is most commonly manifested as IgG-related disease with a fibroinflammatory appearance, typically affects elderly males. And the type 2 is usually a pancreas-specific disorder associated to inflammatory bowel disease. It usually affects younger patients and has no sex predominance. These are the most common areas where the IgG disease affects. And in terms of abdominal ultrasound, what's the typical appearance of it? So it's diffuse hypoechoic enlargement or a focal mass with borders, hypoechoic borders. The main pancreatic duct is usually normal in width, but it may show dilation or areas of stenosis. So there is the peripancreatic hypoechoic rim or halo is described within 50 to 60% of the cases. But the problem is that these findings are non-specific and sometimes they may overlap with other forms of neoplasms or pancreatitis. Excuse me, so can we please put the second question?
Yep, 1 second.
Yeah.
I'm just going to clear the
Thank you.
poll and relaunch it. Okay. Okay, we've got 15 people. I'm going to end the
Good.
poll because we're actually past 7 o'clock. So I'm just going to
Yeah.
launch that. Here we go.
I won't take much longer. Sorry about that. Okay,
There's the results.
perfect. So most of you voted for 30 to 40%, and between 10 and 20 and 50 to 60 is the second most voted. Okay, so here it is that basically 50 to 60% of the cases demonstrate the usual appearance of on ultrasound of the peripancreatic hypoechoic rim or halo. So that means it's basically half of the patients that do demonstrate the classical appearance on ultrasound. Something very quick that I wanted to show you is the usefulness of transabdominal elastography. Most of the new machines have this application, and it might be helpful probably doing more studies in the future. This is an article where they picked almost 60%, 60 patients, 24 patients with autoimmune pancreatitis, the other ones were controls. And what they saw was a significantly elevated stiffness of the pancreatic parenchyma compared to the controls. And also, in a way of interesting finding, is that they found that the stiffness of the pancreatic parenchyma after 2 weeks of treatment was significantly less. So this can also mean that we can use these tools for follow-up of these patients. How are they doing? What are the things? So considering that almost 50% to 60% of the patients do present this appearance, however, if there's a clinical concern and we don't see like definite pancreatic findings, we should also look for additional findings that might suggest IgG4 disease. For example, look for the salivary gland involvement. This is an example of a heterogeneous with hypoechoic areas in one of the salivary glands on the left. And this is the normal appearance of the other salivary gland. Also, look for signs of biliary cholangiopathy, such as strictures of the intrahepatic or extrahepatic bile ducts. And for example, we can look for renal involvement, looking for hypoechoic areas with decreased vascularity on Doppler, which are usually seen, or it can be seen on patients with IgG4. Treatment, if the patient has definite criteria with help of labs or pathology, so they will give them treatment based on immunomodulators or corticoids. However, most of the cases are suspected, and many of these patients underwent glucocorticoid cycles, and we can be useful evaluating them, for example, with, as I shown before, with ultrasound elastography and helping the clinicians to do diagnosis and see how are the patients going with the treatment. So that was it. Thank you very much.
Thanks very much, Rodrigo. Any questions for Rodrigo? Okay, we've lost some people during the course of the evening, but for those of you that have stayed the course, thank you so much. Thanks to all your supervisors and the presenters for doing such an amazing job this first evening. Sorry about the slightly long extension at the end, but we did pretty well in terms of staying on time. So we will see everybody in a couple of months for our next set of citywide rounds. Thanks, everyone. Have a great evening.
I just wanted to say how high quality those cases were, and I really appreciated all the effort the fellows went to. So thank you all.
Yes,
Yeah.
thanks, Anya. Thank you.
Thank you very much, Dr. Chawla.
Bye.
Thank you
Bye.
very much. Have a good one.
Thank you. Have a good one.